Alright guys, today we're going to be going over chapter 26, Psychiatric Emergencies. In this chapter we're going to go over some various psych problems that we will see with in the field and the emergencies that they entail, how we deal with these emergencies, as well as some legal considerations that you want to take when dealing with a psych patient. During this lesson you'll learn some considerations of assessment emergency care for a patient who has attempted or threatening suicide, as well as for patients suffering from other behavioral emergencies. We cannot always see if a patient is having a psychiatric issue. So you want to make sure that you are careful with them and take proper care, because the care that we give these patients could potentially save their lives. Sometimes they just need somebody to talk to them. So your assessment is important to ensure that they get a positive care as they continue through the patient care system. Now, a psychiatric disorder is defined as an abnormal mental condition that significantly impacts one's thoughts, their moods, perceptions, orientation, or memory, and that it also impairs their judgment, their behavior, recognition of reality, or the ability to perform activities of daily living to care for oneself. A psychiatric emergency is a situation in which patients present with behaviors that are abnormal, a threat to themselves or others, are incongruent with their baseline, or have shown a rapid change in cognition. Now, the first thing that we have to figure out with any type of behavioral change, is it psychiatric or is it physical? Because behavioral changes can have numerous different causes, such as low blood sugar in the diabetic patient, hypoxia, seizure disorder, excessive cold or heat, psychogenic substances or mind-altering substances such as alcohol, stimulants, psychedelics, any substance that causes a change in their psychotic thinking or causes them to have depression or panic. Drug use, alcohol use, or the withdrawal from those substances. Table 26-1 goes over some conditions that commonly produce psychiatric symptoms. And we have a mnemonic that we use to help remember these conditions. This mnemonic is MEND-A-MIND. Metabolic, such as electrolytes. Electrical, such as epilepsy. Nutritional, such as malnutrition, thiamine deficiency, drugs and toxins, such as street drugs, arterial, such as strokes or TIA, mechanical, such as a brain injury or subdural hematoma, infection, such as HIV or meningitis, neoplastic, such as a tumor, degenerative, such as Alzheimer's or Parkinson's disease. So that's what we use to help us remember what to look for with a psychiatric issue, or at least to kind of help us lead in the direction. Now, when looking at a patient, all right, we want to look at a variety of different things. Now, this is a version of a mental status exam, which will be useful during your assessment of the patient to obtain specific information to help determine the type and severity of a potential psychiatric emergency. Such as, how are they groomed? Are they well kept or are they disheveled? How are they acting? Are they acting violent? Are they acting confused? And how is their build? Are they well kept? Do they look like they are well nourished, or do they look malnourished? Then you want to look at their speech. Determine whether the responses are appropriate, inappropriate, or incomprehensible. An abnormality commonly observed in psychiatric emergencies is pressured speech, which is an increase in rapid, loud, and accelerated spontaneous speech. Pressured speech is most often observed in patients who are in an active phase of mania, schizophrenia, or an organic brain disorder. We then want to look at their skin, because this can provide a strong indication as to their condition. Is it flushed? Is it cool? Is it pale? Is it clammy? Is it diaphoretic? Look at their gait. Do they appear to be unbalanced or having a hard time keeping their posture? Are they fully alert and oriented to person, place, and time? Do they have the ability to think abstractively, or are they thinking more concrete? Concrete thinkers take things at face value, literally, and cannot conceive of alternative interpretations. Abstract thinkers, by contrast, can see more in depth and come up with meanings other than just a literal interpretation. You want to look at their body language. Do they have dystonia, which is a movement disorder that causes involuntary contractions of muscles resulting in twisting and repetitive movements that are sometimes painful? Tardive dyskinesia is another movement disorder that causes involuntary movements of the tongue, lips, face, trunk, and extremities. Patients who have been treated long-term with dopaminergic antagonist medications such as thorazine or proloxin are prone to tardive dyskinesia. Look at their perception and their thought concepts. Do they rapidly shift from one topic to the next or repeat words despite apparent efforts to make new responses? Does the patient pause for a period before responding to a question? Are they repeating words over and over and over again? What is their mood? What's their affect? Their mood can be identified by paying attention to their affect. With a constricted affect, the patient shows a reduction in intensity of feeling tone. Flat affect, which is the absence in the amount of emotional tone or outward emotional reaction, is common in individuals who are depressed. Labile affect shows as rapid shifts in emotional expression and is most common in organic brain syndromes or intoxication. Are they able to make rational decisions? Do they appear to lack insight into his or her current situation? Then you want to try to figure out some clues. Some indications that the cause is physical might be incontinence, memory loss. Most psychiatric problems develop gradually. You need to obtain the timeline and frequency of their symptoms. Their age is also a factor. Individuals in their late 50s, for example, are less likely to present with a new developing psychiatric emergency. Although it can happen, it's not as common as those in younger generations. The patient has memory loss or impairment. In most psychiatric problems, the memory remains intact, and the patient is usually alert, being oriented to person, place, and time. Hallucinations would also indicate that the cause is mental rather than physical. Note if the hallucinations are visual or auditory. Visual hallucinations are defined as the perception of an object or event with the absence of a stimulus. Auditory hallucinations are defined as the perception of received sounds without auditory stimulus. In addition to auditory and visual hallucinations, there are also olfactory, which is smell, and gustatory, which is your taste, hallucinations. Go through your history and physical. Help determine whether their condition is psychic in nature. Is it their first? A patient who experiences first psychotic break might begin hallucinating or having delusions that were not provoked by any outside stimulus, but rather are a result of mental decompensation. Also, if a patient has stopped taking their medications, he can experience a return of psychiatric symptoms from the medication discontinuation that are not necessarily related to any triggering event, medical illness, or trauma. This is also true for the patient that just began taking a new medication. Some psychiatric problems that we may see, such as anxiety. Anxiety is a state of painful uneasiness about impending problems and, most often, things that are out of one's control. It's characterized by agitation and restlessness, and is one of the most common emotions. Panic attacks often have a sudden onset that rapidly builds to a peak, usually lasting 10 minutes or less. The body becomes flooded with epinephrine in the same way as the common fight or flight response. Agoraphobia is anxiety about being in places or situations from which escape would be difficult or help might not be available. Just the thought of leaving the home can cause impending fear and often cause individuals to avoid specific social situations. Now, there is a multitude of different types of phobias, such as arachnophobia, which is the fear of spiders. So we want to try to figure out what it was that triggered this specific event. Bipolar disorder is when the patient has issues with their mood. To meet criteria for a bipolar disorder, an individual must have experienced both a manic or hypomanic episode and a major depressive episode. Mania, also referred to as the manic state, is a period of abnormally elevated, expansive, or irritable mood that lasts for at least 1 week. When mania occurs, a patient is at increased peril of engaging in dangerous or risk-taking behavior that they normally would not take. In either the manic or the depressive stage, the patient with bipolar disorder can also suffer delusions or hallucinations. Sometimes one phase can potentially last for months. At other times, the patient can swing from one mood to another quickly within a 24 to 48 hour period. Depression is one of the most common psychiatric conditions that we will see. Depression is the leading cause of disability within the United States for those between the age of 15 to 44. It is estimated that 16 million adults had at least one major depressive episode in the year 2012 alone. Do not just assume that an individual is good to go because he has had no predetermined risk factors or obvious triggers for a depressive episode. Depression in an elderly patient is also a serious condition, which may lead to suicide and in which the patient must receive medical attention. Neurocognitive disorders is the actual term that is replacing dementia. Agitated delirium is a disorder and physiological response that is often seen with patients that are taking drugs. These patients can suffer a sudden cardiac arrest during it. And they're typically violent and a danger to not only themselves but to you as well. These patients will present with unusual strength and endurance, agitation, increased tolerance of pain, frenzied and bizarre behavior, unusual speech, as well as hot and diaphoretic skin. Schizophrenia spectrum and other psychotic disorders are those in which mental function is so impaired that contact with reality is completely lost. Patients with this illness suffer debilitating distortions of speech and thought, bizarre delusions, hallucinations, social withdrawal, catatonic behavior, and lack of emotional expressiveness. Paranoia is one of those issues seen in the schizophrenia spectrum and other psychotic disorders. Persons with persecutory delusions tend to brood over real or imagined injustices, carry grudges, and recall wrongs done to them years earlier. Because of this mistrust and suspiciousness of others, they often present as detached, aloof, antagonistic, hypersensitive, defensive, and argumentative. And they tend to focus in on this paranoia, such as thinking that everybody is out against them, thinking that the FBI is watching them, thinking that there's cameras in their phones or in their TVs. Psychosis is another issue seen in the schizophrenia spectrum. Acute psychosis can result from mind-altering drugs, which is the most common cause, or from intense stress, delusional disorders, or schizophrenia, which is another cause. The psychosis can last for only a short period of time, or it can occur as a chronic condition. If a patient presents in a psychotic state, do not discount what he tells you, but rather question it as if you are interested. There is no easy way to differentiate primary from secondary psychosis, especially for EMS providers. Primary psychosis is a true mental disorder. Secondary psychosis is a traumatic condition resulting from some other traumatic or medical cause. Individuals with mental health disorders often use drugs and alcohol as a means of coping with their symptoms. Therefore, each patient who presents exhibiting psychiatric symptoms should also be screened for drugs and alcohol, as psychiatric symptoms and symptoms of substance abuse or use can closely mimic each other. When individuals are under the influence of drugs or alcohol, they have an altered mental state, making them incompetent to make sound decisions regarding their treatment and care. Common symptoms of substances of abuse include alcohol, caffeine, sedatives, cannabis, opioids, and even tobacco. Trauma and stressor-related disorders is a category that encompasses a wide range of diagnoses you might encounter. One to specifically focus on is post-traumatic stress disorder. The concept of PTSD is often associated with combat veterans. Combat veterans are susceptible to developing PTSD due to their exposure and experiences in combat or even in non-combat service. If you are on scene following a reported rape or even with a patient who was sexually abused as a child, a contraindication would be touch. In these circumstances, when needing to provide hands-on care, extensive verbal explanations and asking of permission are necessary to prevent the re-triggering of traumatic experiences. Extrapyramidal symptoms are those that are caused by a blockage of dopamine or depletion of dopamine within the brain. These symptoms often develop as a result of taking certain psychiatric medications, and the motor system causes involuntary muscle movement. Now, there are several disorders that have to do with extrapyramidal symptoms that are medication-induced, such as neuroleptic malignant syndrome, which is a severe, potentially life-threatening reaction as associated with antipsychotics or other dopamine antagonist use. Neuroleptic malignant syndrome typically presents within 72 hours of exposure to a dopamine antagonist, but can also be up to 1 week. Symptoms include extreme elevation in temperature, diaphoresis, muscle rigidity, altered mental status, urinary incontinence, and tachypnea. A few differential diagnoses for neuroleptic malignant syndrome include certain inflammatory or autoimmune disorders, status epilepticus, subcortical structure lesions, and central nervous system infections. You may also have medication-induced acute dystonia. This typically develops within a few days of raising the dosage or starting a medication used to treat extrapyramidal symptoms, such as a neuroleptic medication. These symptoms include abnormal and prolonged contraction of the eyes, head, neck, limbs, or trunk. You may also have medication-induced acute akathisia. This is subjective complaints of restlessness, fidgety movements, rocking, pacing, or inability to sit or stand still. These symptoms typically occur within a few weeks of initiating, increasing, or decreasing the dose of an extrapyramidal targeting medication. Tardive dyskinesia is also something that you might see, which we just previously discussed. These symptoms typically last a few weeks in relation to a neuroleptic medication that has been taken for that had been used for at least a few months, although symptoms can develop more quickly in the elderly population. Neuroleptic withdrawal emergent dyskinesia mimics tardive dyskinesia but results from discontinuation or reduction in dosage of a neuroleptic medication. Medication-induced postural tremor, which is a fine postural tremor associated with use of a medication such as lithium, antidepressants, or valproic acid, with a presentation similar to a tremor from anxiety and stimulants. These tremors present with regular rhythmic movements of the mouth, tongue, head, and limbs, with a frequency between 8 to 12 cycles per second. Antidepressant discontinuation syndrome can develop over abrupt cessation or reduction of an antidepressant taken for at least 1 month and often begins within 2 to 4 days. Symptoms include flashes of light, electric shock sensations, nausea, hypersensitivity to noise and lights, anxiety, and feelings of dread. The symptoms cannot have been present prior to discontinuation or reduction of antidepressant dose to meet criteria for antidepressant discontinuation syndrome. The final one, serotonin syndrome, develops as the result of high levels of serotonin in the body, often from starting new SSRI medication or increasing the dosage. Serotonin syndrome can be caused by illicit drug use. Serotonin syndrome can occur from just an SSRI or SNRI medication, or when combining these with a migraine medication, and it can be fatal if not treated. Symptoms include agitation or restlessness, confusion, rapid heart rate and high blood pressure, dilated pupils, loss of muscle coordination or twitching muscles, muscle rigidity, heavy sweating, diarrhea, headache, shivering, and goosebumps. Serious side effects of serotonin syndrome include high fever, seizures, irregular heartbeat, and unconsciousness. Patients sometimes express their inability to handle the pressures they feel through violent acts. With suicide, this is the willful act designed to end one's own life. At least half of all people who commit suicide has attempted it previously. Risk factors and potential signs of impending suicide include history of mental illness, previous suicidal gestures or attempts, family history of suicide, history of abuse or feelings of hopelessness and like there's no way out, a local epidemic of suicide, recent change in psychiatric medication, recent loss of a loved one, the loss of a job or money or a social loss, alcohol or drug use, divorced or widowed. This group is 5 times more likely to commit suicide. Some other signs would be people who begin giving away personal belongings and cherished possessions, chronic pain, major physical stress such as surgery and long methods of sleep deprivation, suicide of same-sex partner, homosexuality. This is because of this group has a higher incidence of depression, HIV infection, and alcoholism. Expression of a clear plan for committing suicide, and availability of the mechanisms to carry out the suicide, especially access to firearms. Now, the angry, violent patient may be ready to fight with anyone who approaches it and will probably be difficult to control. You might see them pacing or shouting. Keep an eye on their fists because they'll be clenched. Their teeth will be clenched also potentially. If you can identify through your assessment what you believe to be a specific condition, you are more apt to provide the appropriate care for the patient. The mental status exam provides indicators that something might not be right with the patient. Now, our role is not to diagnose the patient. Our role is just to use this exam to help you find out that you are dealing with a true psych emergency. Make sure that you are looking for any risk, because remember, your safety is always your number one concern. Patients that are having suicidal ideations, you want to be straight with them. Okay? Question them, try to figure out if there's a plan, and if there's a means to the plan and intent. Those that are having homicidal ideations, we want to assess them the same as we would for those with a suicidal ideation. But we want to make sure that you're keeping an eye out for signs of potential violence to others while assessing. Ask them questions such as, do you have access to a weapon? Are you having thoughts of wanting to harm somebody? Oops, sorry. Have you thought about how you plan to kill them? And how likely do you think you are to kill them? And what's stopping you from acting on your thoughts? Now, in patients that you suspect to have suicidal or homicidal ideations, you need to contact law enforcement. Because with these patients, law enforcement can actually force a patient to be transported when appropriate by using the application for emergency admission, or pink slip. Now, the pink slip usually can only be signed by specific medical or law enforcement professionals, such as medical doctors, psychologists, deputies, police, and health officers. In general, this serves as a legal document under which a patient's rights are taken away from them for 72 hours for them to be appropriately assessed until cleared by a medical doctor or transported to a psychiatric unit. Now, being pink slip does not necessarily mean that the patient will be hospitalized for psychiatric care, but neither EMS personnel nor police can complete a full psychiatric assessment, which is what is often done in the emergency department to determine any future needs of the patient. Questions to ask to help determine whether the patient might be a danger to himself or others would be determining whether or not this patient's having psychotic issues, such as, are you hearing voices? Are they coming from inside or outside your head? Are they telling you to do things? Can you see things that other people cannot see? Determine if they are having issues of mania, such as, do you feel like your mind is racing and your body cannot keep up? When's the last time you slept? Look into their activities of daily living, such as, what's the longest you've gone without sleeping? How have your appetite and eating been? And then we also want to determine with their history. Are you active with a counselor or a psychiatrist? Have you ever seen one? What kind of medications do you take? When dealing with psychiatric emergencies, you want to remember, every person has their limit. Every person at a psychiatric emergency, including you, is susceptible to emotional injury. Everyone has a threshold, and some can cope better than others. Persons who are experiencing an emotional or mental breakdown are often embarrassed about it, but at that time, those feelings are valid and real. How individuals handle a crisis depends on their previous problem-solving experience, the way they view the problem, and the amount and kind of support or resources available to them. An individual who has experienced repetitive and prolonged trauma can have a decreased ability to handle crises as compared with someone who experiences a single incident trauma. You do not know what a specific physical injury might mean to a given individual. A relatively minor hand injury might seem of little consequence, but it can ruin the career or the personal fulfillment of a person who works with his hands as a profession or a hobby. Because emotional injury is less visible, it is often treated as being less real. It's as real as a physical injury. Mental health stigmas continue to keep patients from seeking the help that they need from fear of being regarded as different or inferior to others. Do not expect instantaneous or automatic results. The patient probably will not realize the extent of the event until long after you leave. You are likely to be the first on scene, and your role is to provide a positive beginning to a long, arduous, and difficult healing process. The goal is not to provide a solution, but rather to focus on providing comfort and support to help the patient achieve a degree of emotional stabilization. Come to terms with your own feelings as you approach a situation, and take the time to understand your patient. Because there might be a variety of cultural beliefs that has these differences have special meanings in these emergencies. When approaching a psychiatric patient, approach them slowly. Actively listen to them. Be supportive and limit interruptions within the interview. Limit touch until rapport is established. and respect their space, because you never know what their triggers may be. And also make sure that you avoid any action, any questions or statements that the patient might construe as threatening to the patient. Other techniques is speaking in a calm and reassuring voice directly to the patient. Let them know who you are and why you're there. Maintain a comfortable distance. And also remember that many patients are threatened by physical contact. Encourage the patient to explain the problem. Never assume that you cannot communicate with a patient until you have tried, even if family or friends have insisted that it cannot be done. Typically, a patient in crisis is willing to return to his state before the crisis. When you give him the opportunity to tell his story in detail, you provide him a sense of control over his care. Look at their eyes, because their eyes can reveal emotions, telling you whether they are terrified, confused, struggling, or in pain. Also, they can telegraph their intentions. If they're about to reach for a weapon or make a leap or dash, their eyes can alert you. Don't make any quick movements. Let the patient see that you're not going to make any sudden moves. And do not lie to your patient. By approaching the patient through the perspective of his strengths, you can help him guide him into identifying strengths within himself that he might have been unable to see, which can be helpful in guiding him to begin overcoming the issue. Never threaten or argue with a patient. And if they are having any visual or auditory disturbances, don't play along with them. If there's any trusted family members that the patient around, use them. Do not leave the patient alone. Also, the use of restraints should be a last-ditch effort. Don't force the patient to make any decisions. Ease them into it. If there's any crowd, disperse them. And also have a planned and clear route for exit in the event that something happens. If you cannot guarantee your own safety, call the police and wait for them to arrive before you leave your vehicle. Be alert if you are dispatched to the scene of a suicidal or potential suicide, that you do not fall victim to a mechanism that the patient planned to use to end their own life. Running an automobile in a closed garage, blowing out a pilot light, and turning on all the burners on a gas stove, and using electrical devices in water are common suicides that can pose risk for an EMT. Another newer method of suicide that poses an extreme risk to the EMT is the use of a chemical suicide bag. If you cannot visually locate the patient, wait for police to enter and secure. If the patient displays a weapon, never ignore or disregard it. Instead, in a calm, non-confrontational way, tell the patient that you want to help, but cannot do so until the weapon is released. Ask for them to give you the weapon. If he doesn't, back out and call for police. And don't always automatically assume that there's just one patient. Sometimes there may be 2 or more persons trying to make a suicide pact. And occasionally, they also try to do a murder-suicide. Go through your primary assessment. Assess their mental status. If the patient has attempted suicide, caring for his traumatic or medical problem rather than his behavioral problem is your priority. For a hanging attempt, for example, establish manual inline stabilization during the primary assessment, followed by complete immobilization. Proceed with your assessment and care based on the mechanism of the suicide attempt. In the patient who is alert and has no significant MOI, try to obtain a history. Paying attention to their medications, this can help clarify if the situation is a psychiatric or medical emergency. Make sure that you note carefully the events leading up to the emergency to help clarify if a suicide attempt is involved. Let them talk about what happened. If you can, interview them in a quiet room where he has privacy, because they may be ashamed and hesitant to talk in front of family or friends. When performing an assessment on a patient who has attempted or threatened suicide, keep some additional guidelines in mind, such as injuries or conditions related to the suicide attempt are your primary concern. Do not trust rapid recoveries. Transport the patient even if they seem to be better. Do not try to deny that the suicide attempt occurred. Your denial can be perceived as condemnation of the patient's feelings. Also, never try to shock a patient out of a suicidal act. Never try to argue him out of it, and never challenge the patient to go ahead. For those that are violent, make sure that you keep an eye on their body posture. Anticipate violence if the patient is standing or sitting in a way that threatens anyone, including themselves. If the patient's fists are clenched, or if the patient is holding anything that could be used as a weapon. Also anticipate violence if they're yelling or cursing, or threatening to hurt themselves or others. Make sure that you give the patient instructions regarding their behavior. Clearly state the consequences of an aggressive behavior before such behavior occurs. Be firm and clear with them. And be prepared to use restraints, but only if necessary. Look for your signs and symptoms. Behavioral changes such as radical alterations in lifestyle, values, or in relationships. Anger that is inappropriate and directed at an inappropriate source. Depression that might involve crying, the inability to function, or feelings of worthlessness or hopelessness, and threats of suicide. Withdrawal, or the loss of interest in people or things previously considered important. Loss of contact with reality, such as hallucinations and delusions that are auditory or visual. Tension, irritability, loss of sex drive. Be alert to the possibility that the patient could become violent and do harm to you, others at the scene, or themselves. Do not let yourself fall victim to the same mechanism of injury as the patient, and never allow a patient to come between you and an exit. Assess the patient for any trauma or medical condition, and remember that what seems to be a psych emergency can arise from a traumatic or medical condition. Keep them calm. Stay with the patient. And if it's necessary to protect yourselves or others, or the patient from harming themselves, use restraints. Never use restraints as a substitute for observation, and never use mental protocols if protocols do not authorize the use of them, and if you are not properly trained in their use. And then transport the patient to a facility where he can get both physical and psychological treatment as needed. Monitor your patient's airway, breathing, and circulation, as well as their mental status. Continue to try to keep them calm and reassure the patient. We restrain a patient only if they are a danger to themselves or others. If you believe that they are a danger, contact law enforcement. Never restrain a patient in the prone position. When they are, the weight of the body places upward pressure on the abdomen and forces the abdominal organs to be displaced toward the diaphragm. This added compression prevents a normal downward movement of the diaphragm, leading to the inability of the patient to take in adequate breaths. This results in a decreased tidal volume and inadequate breathing, which then leads to hypoxia and acidosis, which then further causes agitation and cardiac arrest. It's also impossible to assess their airway and ventilatory status, because you cannot assess for chest rise, thus not allowing you to assess for adequate tidal volume. For these reasons, it is necessary to restrain patients in the supine position. If increased upper extremity movement in supine restraint is a problem, take the supine patient's arms over his head and restrain each wrist to the head of the stretcher. This will limit his ability to move. If vomiting or secretions are a concern, restrain the patient in the lateral position. Restraints used with a patient should be humane. This means that they are padded so that they will not injure a patient who struggles against them. When getting ready to restrain a patient, make sure that you have enough people to overpower the patient before you attempt. Have a plan, and only use as much force as needed for the restraint. A patient who begins to calm down may be hypoxic from the efforts to fight against the restraints. So you want to make sure that you carefully and thoroughly assess their airway, ventilation, oxygenation, and circulation. One person should be assigned to each of the patient's limbs. If the patient is taken down in a prone position to gain control, immediately get the patient into a supine position to allow for adequate ventilation and assessment. Make sure that everybody approaches at the same time, and have one rescuer talking the patient through the process. After you've applied restraints, do not remove them, not even during transport. It may be necessary to remove restraints to reposition the patient. This can be done by removing one restraint at a time and controlling the extremity until it is re-restrained to the stretcher. Reassess circulation frequently to make sure the restraints are not binding. Make sure you document on the PCR why you felt it necessary to restrain the patient, and thoroughly document the technique you used for the restraint. Under most state laws, any adult of sound mind has the right to determine whether he will or will not be treated, or more specifically, touched by another person during said treatment. In most states, anyone aged 18 or over is considered an adult, and anyone under the age of 18 who is in the armed services or is married or a parent is also considered an adult or an emancipated minor. If you cannot find a responsible adult to consent to the treatment of a minor or of a parent without mental competence, or if an adult patient is unresponsive, you can still go ahead and treat. You will act in such cases on the principle of implied consent. Your best protection when against legal problems when dealing with emotionally disturbed patients is to document carefully and thoroughly all aspects of the encounter. If a patient refuses care who has the capacity to understand and make a reasoned decision, complete a refusal of care form and then have it signed and witnessed by a police officer. If a patient threatens to hurt himself or others and you can demonstrate reason to believe that the patient's threats are real, you can transport that patient without their consent. However, you must be able to show that your belief that the patient poses a threat is reasonable. The amount of force deemed reasonable depends on the situation, such as the size and strength of the patient, the type of behavior exhibited, the mental state of the patient, as well as the method of restraint. Soft restraints, commonly called humane restraints, and straps are generally considered reasonable. Metal handcuffs are not. Do not use metal handcuffs unless you are specifically trained in their use. If the police apply handcuffs to the patient, ensure that an officer accompanies the patient in the ambulance or drives directly behind the ambulance in case the handcuffs would need to be removed quickly. Also, be aware that a patient who has become calm following a period of combativeness and aggression can suddenly revert to the earlier behavior. In any case where you might need to use reasonable force or transport without consent, the best way to protect yourself legally is to involve your chain of command. Before you restrain any patient for any reason, make sure that you contact medical direction. If a restraint of any way, make sure law enforcement personnel is involved, because law enforcement can help protect you from injury and they can serve as credible witnesses. The best way to protect yourself against false accusations by a patient is to carefully and completely document everything that happens during the encounter, including detailed aspects of the patient's abnormal behavior. To protect against these kind of charges, consider employing these measures, such as involving other responders who can testify that there was no misconduct. Use responders that are the same gender as the patient. Involve third-party witnesses and carefully document your physical assessment. Alright guys, that's it for this chapter. If you have any questions, please be sure to write them down or send them to me either through Remind or through Blackboard. Make sure that you are knocking out your Brady Labs. If there's nothing else, y'all have a good rest of your day or evening, and I will see y'all next time in class.